Sure, I'm Dr. Rees. I'm one of the geriatricians that practices in Sioux Falls, South Dakota. I received my undergraduate degree in medicine at Kansas City University of Medicine and Biosciences. I did my internal medicine residency here in Sioux Falls at the University of South Dakota, Sanford School of Medicine, and my geriatrics fellowship was also done here at the Sanford School of Medicine at USD.
Wonderful, thank you. And I'm not sure, were you going to share your screen, or would you like me to do the slides and you can just let me know when to advance? Either way is fine with me.
If you could share your screen, that would be perfect.
No problem. Okay, are you seeing full screen or?
I'm seeing the full screen, you're good.
Okay.
So you can go to the next slide. So we're going to talk a little bit about depression today. The biggest objectives is trying to discuss some of the risk factors, signs, and symptoms in the geriatric population that may be a little bit different than the normal population. We're going to identify differences in some of those things that you look for from a treatment perspective and how to better help our geriatric population with depression. One of the things when you think about depression is how often do you see that? And from this slide here, you see that 35% of residents in a long-term care facility have some bit of depression. I do think that you see maybe even about that same percentage of people that are at home, maybe a little bit less. It kind of depends on the population that you're looking at. But I think somewhere around 25 to 30% of the geriatric population will have some bit of depression in their lifetime. Of course, it's difficult to get an exact prevalence just because of underreporting and or undertreating of this disorder in the geriatric population and in the general public in any way. So when you're thinking about depression, it's hard to get exact numbers, but 25 to 30% is probably a fairly good, close, rough estimate of what's happening from a depression standpoint in the geriatric population. Some of the underlying causes or some of the underlying things you think about, they have a little bit different presentation sometimes in the elderly. There's a focus on medical illnesses rather than mental health. Often our geriatric population has lots of other medical problems, and so you're trying to work out their diabetes, their hypertension, their congestive heart failure, their COPD. You're trying to do all of that during, you know, a 30-minute visit or a 15-minute visit, and then trying to get to their mental health makes it difficult to find the depression in that individual, especially if you're not paying attention to that. View sadness or depressed moods as kind of a normal sign of aging, and sometimes we view that as a normal sign of kind of some of the loss of independence. And so you have somebody that's in a nursing home and they're a little bit more sad, maybe a little bit more depressed mood, and you think, oh, it's because they just moved into the nursing home or because they're in a nursing home now and they don't have the independence that they used to have. So I think often we sometimes downplay some of those symptoms and forget to manage and monitor that. And then sometimes the symptoms of depression can mimic other chronic diseases. So when you have congestive heart failure and you have a little bit of fatigue from congestive heart failure or COPD and you have a little fatigue from that, sometimes that fatigue can mimic some of that congestive heart failure, but really be more of a mood or a depression problem. You can move on to the next slide. So we're going to try to do a little bit of a case study presentation as well during this, and we'll kind of talk about this is the same case throughout the whole thing. This actually came from a case that was seen at the place where Robin and I both work, which is at the Avera Telehealth Center here in Sioux Falls. So it was a 75-year-old gentleman who has a past medical history of stroke. He recently moved into the nursing home about 6 months ago, and I think his stroke was about the time 6 months ago that caused him to move into the nursing home. He has a couple children who live far enough away that they don't visit the nursing home very often and really haven't been back to the home as often as he would like. He, since moving into the nursing home, has become a little bit more isolative. He's not been out and doing activities. He doesn't often spend time with those in the nursing home themselves. He has been sleeping much more as well. And you've noticed maybe a little bit of a loss in appetite. And when he first came in, he had a little bit more motivation, was a little bit excited about the new environment, but that excitement has kind of settled off now and he's a little less motivated to do things. You can move on. So some of the risk factors for depression are similar risk factors for the young: alcohol or substance abuse. Don't forget about alcohol and substance abuse. I've recently had several clinical patients here that I've been seeing lately that have had some alcohol abuse, and it had been missed by several of the preceding providers, and so treating the alcohol abuse has helped with their depression considerably, and that's been the main management that we've done is treating the alcohol or substance abuse. Medications can often be associated with depression, so I usually just look those up. We're not going to share the whole list with you. Vision and hearing impairment limit the interaction in the environment, and so that often will cause a little bit of isolation, so it's hard to say whether the hearing and vision impairment is causing the depression or the vision and hearing impairment is contributing to depression and contributing to more isolation, and then more depression in that regard. History of suicide attempts also increases risk for depression in the elderly. Any psychiatric hospital admission increases risk of depression. Diagnosis associated with depression prevalence, like coronary artery disease. We'll talk a little bit more about that here later, so I'm not going to go through all of those, but coronary artery disease is one that you think about specifically. Sometimes some of the breathing treatments you think about a little bit with depression. Some of those maybe go a little bit more with anxiety. Certainly a change to environment, stressful losses, loss of function. So if you just had a big stroke, that sometimes will cause you to have some bit of concern and be something that makes you feel like you've lost something that you hadn't had lost before. And so a loss can lead to depression. And then of course, history of depression or mood disorder also increases the risk for depression. You can move on. Medications, we do have a little bit of a list here. So antiarrhythmics, anticonvulsants, the benzodiazepines, always think about that. Carbidopa, levodopa, especially in your Parkinson's patients. Beta blockers cause depression. Clonidine, digoxin, glucocorticoids, H2 blocker, and opioids. I think the big ones that I often see, benzodiazepines, opioids, beta blockers, those are the main ones that I find are quite problematic. The anticonvulsants also can lead to that. And then of course, I've seen quite a bit of depression in the Parkinson's patients. Question is it Parkinson's related or is it more carbidopa, levodopa related? And that is difficult to tease out. And so, but those medications are the ones that you often think about associated with depression. Other diagnoses that you think about or that can be associated with depression or lead to depression, as we talked about, the coronary artery diseases, so you can see heart failure, MI, open chest procedures, all of those things you think about can cause an increased risk of depression. Alcohol use, we talked about, stroke, and especially if you have something that loses major function and or causes a change in living environment. Chronic pain, certainly one that causes depression both in the elderly and in the young. Any of the neurodegenerative disorders, again, that can be true for elderly and the young. Cancer increases risk of depression, COPD, diabetes. One that I think we don't sometimes think about is abuse. And so don't forget that abuse can be a trigger or a diagnosis of depression. I just heard recently about an individual, it's not one of my patients, but an individual that had suffered some abuse and has been going through depression their whole life related to that abuse that they suffered. Now, he's a younger patient, but that can be true for the elderly as well. And then schizophrenia also increases risk of depression, and so something you should think about. Our schizophrenics are living longer, often making it to an older age. Sometimes their schizophrenia is not quite as prevalent, but the depression becomes more of an issue and something that you should pay attention to. Next. Some of the signs and symptoms that you need to look for, some of those things that we talked about, social withdrawal. So our patient that we talked about earlier had some of that social withdrawal. Hypersomnia, that patient was sleeping much more than normal. Insomnia also can be a sign of depression, so you can either sleep more or sleep less. Difficulty concentrating, I don't think we saw too much of that in our patient, but we did see that they were not as motivated as what they were before. Obviously, depressed mood, thoughts of suicidal ideation are some of the other key features of depression. feelings of hopelessness and worthlessness and helplessness often become that way. I have many geriatric population, especially by the time they get to the nursing home, that say, I don't feel like I have any purpose. And so screening for depression in that individual, I think, is very valuable because there may be quite a bit of depression going on. And if you treat that depression, sometimes you can help them feel a little bit more less helpless and a little bit more helpful. Guilt sometimes can be a sign or symptom. So if you have somebody that's complaining that they're the problem all the time, or nobody likes them because of X, Y, or Z, that might be something you think about as contributing to some of their problems. Slowness in activity, slowness in speech, some of those things, psychomotor agitation or retardation, are often quite common as well. Failure to thrive, this is one of those things that when you have somebody that is quote unquote failure to thrive, I think that term's not a great term right now, so frailty would probably be a better term for that. But when you see somebody that's frail, depression, I think, should be high on the differential diagnosis of that frailty, or maybe a contributing factor to the frailty. Certainly pain, so you have somebody that's having chronic pain or always having pain, or maybe a pain that you can't figure out the source of, and their pain kind of migrates around. That might be a sign that maybe some depression is contributing to their pain symptom. And then weight loss certainly can contribute to that. That goes along a little bit with the change in appetite. So you'll see a change in appetite, you see a little bit of weight loss associated with that. You can move on to the next slide. So looking back at our patient, you want to kind of focus on the specific symptoms. So we looked at the fact that he was sleeping more. We looked at the fact that he was less motivated. We looked at the fact that he was less engaged in activities. And you want to kind of determine the duration of those symptoms. So how long has he been having that problem? And if you looked at our patient was having these symptoms probably for the last month, maybe month and a half. And so depending upon when you started seeing some of that changes, those are kind of some of the things that you're looking for is, okay, as you're trying to determine if depression is contributing to what his withdrawal, his lack of motivation, his increased somnolence, those are kind of some of the things that you clue in on to help you kind of sort out whether this is depression or whether this is maybe just an underlying stroke that's causing problems or something else that's contributing to that problem. You want to look and ask the collaborators and caregivers to provide some of that information. And so some of the information about him not being as motivated, not being as participatory in the nursing home activities were given by the nurses at the site itself. And sometimes the CNAs are very valuable sources of that information. I find sometimes the CNAs get a little uncomfortable when they talk to me. Not that I hope I'm not that scary, but sometimes they do get a little uncomfortable. And I still try to communicate with them because often they are the ones that understand what's going on best with that patient. You can ask about self-harm. That's not a big deal. And then his PHQ-9 was a 10. We'll talk a little bit more about his self-harm because he did pose some self-harm issues, and that'll come back down later in the case, so we can move on. So when you're thinking about screening for depression in the elderly, it's recommended upon admission and any change that occurs in function or medication or really any change that's happening in that individual. In my clinic that I do here in Sioux Falls, we screen at every visit. So we're screening for depression every visit. We happen to use the PHQ-9. Sometimes that's not the best screening score for depression in some of my patients that come to the clinic. That's a little bit harder in the nursing home. There's also the PHQ-9 observed, and I think you see a lot of more of that being used at the nursing homes themselves. The geriatric depression scale is a very good scale. We partly don't use the geriatric depression scale here because I'm in a family medicine office and they all use the PHQ-9, and so I have a hard time changing from a PHQ-9 to a geriatric depression scale. And then the Cornell scale for depression and dementia are all very good and validated studies. And so we'll go through each of these over the coming slides. So the first one we'll talk about is the geriatric depression scale. So if you could move on to that slide. The next one. All right, so the geriatric depression scale is very well studied in the geriatric population. It's got the best sensitivity, the best specificity among the other screening tools listed when it comes to geriatric depression. I wish I could get my clinic to switch over to this, but me being the only geriatric provider would be very difficult for the other 7 or 8 providers that I have working on this floor. The patients do need to be cognitively intact, so it doesn't work very well if you're looking at somebody with dementia. And so that's why often this is not the scale that they use, I think, in the nursing homes, because it's you have to have a cognitively intact patient. It's 15 questions. They're all yes, no, 1 point for each answer. Greater than 5 suggests depression and should have maybe a little bit more of a workup. Greater than 10 indicates depression and should be treated. So greater than 5, maybe they have depression and you might need to sort out that a little bit more in fine detail. Greater than 10, yes, they have depression and should be treated. Here is the way you can access that scale on the bottom of this slide. We're not going to go through how to do all that, but it's very good tool and very useful. So I do that occasionally. If the PHQ-9 is difficult for me, you can move on. So I sometimes will go to the geriatric depression scale if I have problems with the PHQ-9, and I'll do that right in the clinic by myself. So this one is the Cornell. It's validated for residents with dementia and frailty. So this is a good one to use sometimes in those nursing home settings. So you could use that in the nursing home setting or somebody that's coming into the clinic with dementia. Information is provided by caregiver as well as discussion and observation. It's usually done ahead of time. So usually you're gathering some of this data about a week ahead of time, which is why I don't use this in the clinic very much, is because it's hard to get that information a week ahead of time. Though I usually have the appointment scheduled that far in advance, but sometimes getting the caregiver and all of those individuals to gather this information for me ahead of time has been a little bit difficult in my clinic, partly because I have a new clinic and I'm not here every day of the week, and so that makes it a little bit more difficult. But this one does have some good validated information on that and would be good for like a nursing home where you could have the nurses in the facility do that. The score is from 0 to 3 is unable to evaluate, so you can't really get a good sense of what's happening if they score from 0 to 3. If they're greater than 10, they probably have depression. If they're greater than 18, they definitely have depression. Again, the resource for the Cornell scale is right here on the bottom of this page, and so you can use that to get access to that if you want to try to use that in your practice. I think it's a good scale. Just trying to sort out the differences is hard to do sometimes, and so that's why we don't use it. That's why I don't use it here. You can move on to the next slide. PHQ-9 and PHQ-9 observed. So the observed obviously stands for observed. So it's more of an observation as opposed to a direct questions to the patients. The PHQ-9 they have to be cognitively intact. They have to be able to remember 2 weeks beforehand. And if they had any of those symptoms, it becomes very difficult sometimes in the clinic setting, which is sometimes why I switch over to the geriatric depression scale in the clinic here if I have some questions about the PHQ-9. PHQ-9 can be used is recommended by the Medicare and Medicaid for residents who are not able to communicate for themselves. And it also adds irritability, which you don't see in the PHQ-9 alone. So one of the symptoms that you might be able to see is some irritability. I don't know if we talked about that too much in the symptoms aspect, but sometimes patients that are becoming more irritable is a sign that maybe they have some depression. I find that the PHQ-9 is very good. Sometimes I'll start with just the PHQ-2, which are the first 2 questions in the PHQ-9. If those 2 are negative, going down and doing the rest of the questions may not be very helpful. The PHQ-9 observed is often done in the nursing home, and I use that quite a bit when I'm going back and forth to my nursing home patients. I have some facilities here that are assisted living, and we have been trying to get them to do some more of the PHQ-9s or the PHQ-9 observed, so that when we come see them, it's a little bit easier for us to do. This questionnaire is right there at MedCalc, and so that's another resource that you can use to try to find that if you're looking for it. Both all validated and very good studies did. So any one of those 4, I don't think is a concern to be used. We'll look, I think the next slide is reviewing of the patient again. So The lab studies were all normal, so as BMP, CBC, all of that was normal. We did do a TSH, which was in the normal range at 2.01. Some might argue that that's kind of at the upper end of normal and may need a T4 to evaluate a little bit more thoroughly. We did not do a T4 in this situation. He did have a recent urinary tract infection. We did not repeat a UA as he had just recently had a urinary tract infection. We did do a vitamin B12 level, which was 427. And we also did a folate level, which was 8.2. I don't often do folate levels. I don't find them to be terribly helpful. If I think they need folate replacement, I often will replace the folate level. But in this situation, we did do a folate level and had a 8.2. So those are kind of some of the things that our patient, and we'll talk a little bit more about what testing we feel would be valuable in patients with depression in the next slide. You can move on to the next one. So diagnostics to consider: electrolytes. So you want to look at sodium. Obviously, if they have a low sodium, that can contribute to depression in and of itself. And so that might be something that you think about evaluating when you're thinking about depression. Kidney function, if their kidney function's off, BUN, creatinine, those types of things also can potentially lead to a little bit of concern for depression, and so are very helpful. CBC often can cause some fatigue, can cause some other things that mimic depression, and so the CBC is sometimes helpful in that situation. I didn't list the electrolytes and kidney function of our patient, but they were all normal, so I wasn't going to list the normal values in that one. Of course, the TSH and free T, we didn't do a free T4, but the TSH was normal. Free T4 if you need it. Vitamin B12 and folate also are considerations, as sometimes vitamin B12 deficiency can contribute to some bit of ongoing depression symptoms. I had a patient recently here in the clinic that was having some difficulty and had a little bit of depression. I started her on some oral vitamin B12 replacement because her vitamin B12 level was around 220. And she called back actually today while I was here at clinic and said, "I am feeling so much better, thank you." And so vitamin B12 may not necessarily be causing the depression, but may be mimicking the depressive symptoms. So if they have a B12 deficiency and you replace that, sometimes you can get them feeling quite a bit better. This patient was also having some other symptoms, and so thinking about a B12 is also very helpful. Those are the main diagnostic considerations for patients with depression. Next. So in order to make a diagnosis of depression, as we talked about, those scores up there are helpful in determining if you have depression, and this is the criteria itself that tells you if they have depression. So the criteria includes depressed mood, in addition to 4 symptoms over 2 weeks. So that's why the PHQ-9 is written the way it is, because it helps you assess these 4 symptoms over the last 2 weeks. And that's how you can tell if they have a depressed mood or not. And so the symptoms are listed there. I'm not going to necessarily read them all to you, but we'll talk about a few of those. The other criteria is a loss of pleasure in addition to 4 symptoms over the last 2 weeks. So you don't have just to have a depressed mood. Sometimes it's hard to figure out a depressed mood, and especially I find in some of my dementia patients, depressed mood doesn't seem to be anything that you can see, but they do maybe have a loss of pleasure in activities. Like our patient that we were talking about, he was not coming out and doing some of the activities that he was when he first moved there. So he had kind of a loss of pleasure in some of those activities. And so that is something that kind of clued us in that maybe depression was a little bit more. He also had some suicidal ideation, which also clued us in. But I think a loss of pleasure is something that you might see more often in a demented or a geriatric population as opposed to just a depressed mood. Though you do often see depressed mood as well. And so I'm not saying that you only look for loss of pleasure, but those 2 things are the 2 things that really kind of help clue you in that maybe there's an underlying depression. Then you want to look about appetite. So is their appetite changed? Are they eating more? Or are they eating less? Because both of those 2 things can be evidence of depression. Weight loss would be something that you can help with the appetite. So maybe they say, no, I'm not eating any, my appetite's been the same. And all of a sudden you look and you're like, you've lost 10 pounds since the last time I saw you 6 months ago. Oh boy, that is a clue that maybe that's appetite is more of a problem. Sleep pattern changes. Our patient did have sleep pattern changes, right? They were sleeping much more frequently than normal. Changes in psychomotor activity, so moving slower, doing some of those things much more slower or much more rapidly, so sometimes even a rapid change. Often when you think about the rapid side, you're thinking more bipolar, though in the geriatric population, bipolar is less common. And so that might be something that if you have a 75-year-old that's a little bit more hyperactive, it may be a sign that depression is contributing to that. Decreased energy certainly is something that is evidence of depression. And then I think difficulty concentrating is something else that you see. That's going to be very difficult if they have dementia, because sometimes difficulty concentrating is a sign more of dementia more so than depression. And so again, sorting out sometimes that dementia versus depression is very difficult because of the fact that a lot of these mimic or can mimic some of those things. So people with dementia certainly have a change in appetite. They certainly have a change in their sleep patterns. They certainly have less energy. They certainly have difficulty concentrating. So all of these things, right? So almost with the diagnosis of dementia, you have a diagnosis of depression. And so it becomes hard to sort out. And so that's where concentrating or focusing on a few of these things is very helpful. So difficulty concentrating, and I would say maybe a change, especially if you have somebody that's in a nursing home. If you're seeing them in a nursing home, they've been there, living at that nursing home for years and years and years. Our patient was only 6 months, so we don't have a real good history of what he was like. But if he was having difficulty concentrating since he got to the nursing home, that would be a clue that maybe depression is more outweighing his memory issues, though it could also be a sign that maybe dementia is developing and something that we should take and evaluate a little bit more closely. And then certainly thoughts of suicide make depression a little bit easier to identify. You can move on to the next slide. So looking back at our patient, some of the things that we tried. So when you're thinking about treatment for depression, just with anything in geriatrics, there are pharmacologic treatments and there are non-pharmacologic treatments. I always liked the non-pharmacologic treatments as my first option, though sometimes if the patient is very depressed and you need to treat rapidly, doing both non-pharmacologic and pharmacologic at the same time is a good option. And so we did both of those two things. So we went down the non-pharmacologic option and we went down some of the pharmacologic treatment, and we'll talk a little bit about that. So from a non-pharmacologic treatment standpoint for depression, you want to kind of focus on areas and things that you can do to help improve. So a lot of times when you think of depression, you think of people isolating, you think of them having slow activity, you think of them not eating or maybe eating too much. You think about some of those types of things. And so as you're thinking about non-pharmacologic treatment, you're thinking about ways to get them to improve in all of those areas. So as you think about somebody that has been not participating in activities, so like our gentleman was not participating in the group activities like he was when he first came into the facility. So trying to find an activity that he really enjoyed and trying to find that activity and then focusing on that activity. So I have many patients in the nursing home who absolutely love playing bingo. And so they play bingo all the time. And when they stop playing bingo, that's a sign to me that something's going on. And so then trying to get them back to playing bingo is always a good thing. And so trying to get them to enjoy those types of activities. This patient that we're talking about didn't really have any specific activities that he really enjoyed at the nursing home. And so it was a little bit difficult. And then here with COVID lately as well, it's become even harder because sometimes the activity they enjoy is going out and exploring or doing. We had this particular home likes to do some fishing trips for the men, and so But now with COVID-19, we don't get to go out and do the fishing trips, or weren't able to do that for a period of time. Now they're starting to allow them to do some of that. And of course, now it's getting too cold to do some of those types of activities. But trying to focus on activities that they enjoy and trying to do more of those types of activities. So I can remember a patient that I had at one of the, not nursing homes, but one of the assisted livings here in town. And the patient was starting to have a lot more depression, and they were trying to get him to go to bingo and trying to get him to do some of those things, but those were not activities that they enjoyed. And so one of the activities coordinators went and talked to them and found out that they like to do puzzles. And so the activities coordinator would go into the room with the patient and help them with the puzzle in their own room. And so that kind of helped with the mood during that time frame. Pastoral visits are always something that can be helpful, especially if they enjoy pastoral visits. Obviously, if they don't enjoy that, then that probably wouldn't be the right approach. This gentleman that we're talking about, the case that we had, did enjoy pastoral visits, and we increased the number of visits and tried to find ways to get that to work. Family visits obviously are also very valuable, assuming that the family is close. Sometimes family visits can also be a strain if there has been a strain in that relationship, and definitely if there has been abuse. And so family visits may not always be the best thing, though often are very helpful. And I think for our gentleman in particular, he wanted his family to visit more often, but they lived kind of far away. It was a little bit difficult, and with COVID going on, they weren't able to visit for a little bit of time. And so trying to find a way to get him to visit was a key for us in helping him with his treatment. And of course, we did the FaceTime and some of those types of things to try to help with that. Nursing home outings, always a good activity, getting out of the nursing home. When I was a hospitalist, when I practiced hospital medicine, I often told people, you don't sit in a room all day ever. There's nobody that sits in a room all day. Even when you're in prison, they don't let you sit in your jail cell all day. You get out and you go do outings. And so being confined to a home or a nursing home or one room often is detrimental to your mental health. And so trying to be able to get out and be outside of your home environment is always helpful. So that was always my argument to the patients that were in the nursing home, is you don't need to be in this room all day, 24 hours a day, 7 days a week. You need to get out of the room. You need to go do something outside of this room. And so I was often trying to convince them of that. And I think the same thing applies in a nursing home. Being out of the nursing home may not be able to happen for some of the residents, but for those that can, I do think there is something that is beneficial to mental health with that. There is quite a bit of evidence that being out in nature is very helpful. A little hard to do that in the nursing home population, but not very hard for our home elderly patients. They can be out going for a walk, and they don't have to go into the woods and do a 3-day hike with nothing. They can just go to the local park and spend a little bit of time at the local park walking around or doing those types of things. We started this individual on escitalopram 5 milligrams daily here in the beginning, and then we did do close follow-up, partly because of some of his suicidal ideation. You can move on to the next slide. When we talk about treatment, go ahead and move on to the next one. When we talk about treatment, we talked a little bit about pharmacologic versus non-pharmacologic. Cognitive behavioral therapy is very helpful. You have to find somebody that's very good at cognitive behavioral therapy. So wherever you're practicing, I would maybe go around to some of the social workers, psychologists, anybody that you can find that maybe does some of this cognitive behavioral therapy. Talk to them a little bit about what they do and how they do it. I have a gentleman that's here in Sioux Falls that I really like, who I think does a very good job of cognitive behavioral therapy. Unfortunately, he has fallen ill, and so I'm having to look for somebody new that helps me with my cognitive behavioral therapy, but that's also very good. Interpersonal therapy, again, maybe somebody that you find in your local community that does very well with that. Exercise, I often tell my patients that there has not been any diagnosis that is not improved with exercise. And I don't know if that's entirely true, but that's what I always tell them. So exercise is always a good thing. maybe even doing a little bit of photo or light therapy. So maybe looking at trying to get a different light in their situation. Often that can be done just by saying, instead of sitting in your room all day, why don't you get out and go sit by the windows or go do something like that? But you can also do light therapy in and of itself. Psychoeducation is very good. And then participation in social activities, trying to get them socializing, trying to get them involved with other individuals in the community. So that's mostly non-pharmacologic therapy. When we talk about pharmacologic therapy, there are numerous different medications, and we'll kind of go through each of these separately. And so I'm not going to go through this whole list, but we'll talk first about SSRIs. So if you move on to the next slide, we'll go right into the SSRIs. So the SSRIs, the things that you think about: sertraline, escitalopram, citalopram, and fluoxetine. Fluoxetine often is used for the obsessive compulsive behavior. So if you have somebody that has maybe some obsessions and compulsions, the fluoxetine might be a good place to start. It has a little bit of anticholinergic properties, so you have to watch that a little bit. Obviously, hyponatremia is something that can occur with the SSRIs. It's interesting, when I look on it in some of the literature, it says less than 1%. And so we prescribe a lot of medications that are less than 1%, but everybody knows that SSRIs can cause some hyponatremia, and I've seen it. So it's surprising to me that it's actually that low of a prevalence. I suspect maybe it's actually a little bit higher than that. Certainly nausea and or diarrhea and or GI upset is one of the common side effects. So if they're losing weight, SSRIs might be one you use with a little bit of caution, because sometimes that can cause that problem. Most of the time, I have not found that to be the case in my practice. When I started somebody on an SSRI, they actually gain weight, partly because of the fact that they do feel better. Need to watch for QT prolongation, especially with the use of citalopram, and that dose it should be dose reduced in the elderly. So don't forget that there is a dose reduction for citalopram and escitalopram. When I was talking to one of my psychiatry partners, they said the escitalopram they don't worry about as much as the citalopram. They feel like the QT prolongation is worse in the citalopram than the escitalopram, and so they often dose reduce that when they don't do as much for the escitalopram. I still use escitalopram at lower doses than I would in the non-geriatric population. Next. So SNRIs, I think that's kind of the second line treatment for depression. When you're thinking about SNRIs in the elderly, I think they're a little bit less well tolerated than the SSRIs, and I think they're less well tolerated in the older population than in the younger population. Venlafaxine, the extended release version, can increase blood pressure, so you need to watch that, and it needs to be tapered over a period of time. So don't forget the venlafaxine should be tapered slowly, and sometimes we'll taper these things over a week and be off the medication. Venlafaxine you might do a month from a taper perspective to try to get patients off the SSRS, the venlafaxines. I sometimes will even taper slower than that because I don't want them to have any problems. Skipping a dose even a couple hours sometimes can make them feel like they have a flu-like illness, mostly with the venlafaxine. The Cymbalta or the duloxetine, I haven't seen as much of a problem with that, though I've had a few patients here recently when I've started them on duloxetine have had some neurologic decline and maybe some bit of increased anxiety. And not saying that it doesn't work, because I have several patients that it's working just fine on, but something to watch for with the SNRIs. The duloxetine you don't have to taper as slowly as the venlafaxine. That one can be tapered over a week like you would do more with your SSRIs. Next. Tricyclics antidepressants. For use in the elderly, I am a little cautious with that. I don't usually use that very much. Diazepamine and nortriptyline probably are the best ones when you're looking at tricyclic antidepressants. Watch for the anticholinergic side effects: blurred vision, urinary retention, constipation, dry mouth, and postural hypotension. So if they're having some bit of postural hypertension already, tricyclic antidepressants probably isn't going to be your go-to drug. This is not typically one that I would go to as a first-line therapy. I would typically start with the SSRI or SNRI. This would maybe be adjunctive, or maybe if I was treating a specific thing, maybe if they were having pain and depression and I tried them on duloxetine and that failed, I might go to a tricyclic antidepressant, but often I'm not starting with the tricyclic antidepressants. Next slide. Bupropion, this is probably a better one to be an adjunct, so better one to add to an SSRI or SNRI. It can be a little bit more stimulating. So if they're having some increased behaviors, especially if they have some bit of dementia and they're starting to be a little bit more anxious, probably not the best one to start with that. As you can see, it causes a little bit of jitteriness and sometimes some insomnia. It does work pretty well if they have some daytime sedation. So our patient that was a little bit more sleepy, bupropion might not have been a bad choice, though escitalopram I think also helps a little bit with some of that daytime sedation as well. You can have the opposite effect, though. You can also get lethargy and fatigue with bupropion. It does lower the seizure threshold, and seizures are more common in the elderly. And so, again, it's not one that I often start with, is more one that I usually add to a medicine if I'm having problems with one of, and I don't have the depression well controlled with one of the other medications. Obviously, you start at a low dose and titrate up. That's the key tenet of geriatrics. So I very rarely start anything at the high dose. Next. Trazodone. The psychiatrist that Robin and I work with doesn't like trazodone. He doesn't feel like it works very good. And I have better success with it helping with sleep. So it can cause the sedation, as we talked about, lower doses for sleep. Mostly if you're talking about depression, most of the time the depression doses for trazodone were titrated up pretty high, and you do have to dose reduce a little bit in the elderly, so 300 to 400 milligrams per day is the max dose. Usually fairly well tolerated by the elderly, so not probably a bad drug to use. Again, I don't often use it too much for depression. I use it more to help augment with sleep problems if we're having that in depression. So sometimes I will use it for depression itself. I have a few patients that are on it 3 times a day and do pretty well with that. It does not have the anticholinergic side effects like the tricyclic antidepressants. So maybe one, if you're thinking about, you've tried an SSRI, you tried an SNRI, and they just haven't worked, maybe a trazodone dosed a couple times a day, maybe not a bad or a reasonable option. Usually you don't do high doses in that, and sometimes people can tolerate that fairly well. Next. Mertazapine, it's a multi-receptor antidepressant. It's another one of those alternatives for failed SSRI treatment. It's one of my more commonly used medications that I use in the elderly. It helps a little bit with appetite. It helps maybe a little bit with sleep. And I should say it helps maybe a little bit with appetite and maybe a little bit with sleep. Lower doses typically work better for sleep. I think the higher doses work a little bit better for depression. And so often when you're using this, you have to titrate up the dose to try to help. I have had very good success with this medication. It's often one that I augment with an SSRI, so I'll start the escitalopram, titrate up to 10 milligrams, and then add in mertazapine if we're still having a little bit of difficulty. And by that time, usually I have pretty good success in getting them feeling fairly back to normal. It can cause a little bit of sedation, as we talked about with the lower doses, and it may cause a little bit of appetite increase. So it's not maybe the best for those that are not eating or that are obese or not wanting to gain any weight. I just had a patient I started on this the other day at clinic, and they were a little bit worried about the side effect of increased weight gain. Next. They stopped that medication shortly after that. So when you think about somebody, if you started them on one of those treatments that we talked about, the SSRI, the SNRI, and they just didn't respond, what do you do next? So reconsider the diagnosis. Well, maybe I missed this diagnosis. Maybe this is more dementia than depression, or maybe this is just related to their coronary artery disease and the recent CABG. So reconsider the diagnosis. ensure adequate dosing. Maybe you just didn't titrate up. You know, you started at sertraline 25 milligrams once a day, and you got to 50 milligrams once a day. Sertraline should be dosed probably somewhere around 100 milligrams a day to 200 milligrams a day to be most effective in depression. And so maybe you just didn't get to the right dose for that elderly patient. And so maybe you do need to titrate that dose up a little bit higher. Sometimes if you've been only tried an SSRI, maybe trying an SNRI, or maybe trying a Remeron or a Bupropion, or maybe even a trazodone would be something that you could switch to see if that would help. Potentially adding a second agent. Often I titrate up to the maximum dose and then add in the second agent. If I haven't seen much benefit with my first dose, sometimes I won't titrate all the way up to the maximum dose. Sometimes I'll titrate up to what I think is the therapeutic dose. If I don't see any response, I might either augment or I might change that to a different medication to see if that works better. So it kind of depends on what you're looking at there. So augmentation with another agent versus titrating up is kind of a little bit of a nuance. I typically will titrate up to where I think is a therapeutic dose. So escitalopram, maybe 10 milligrams a day. If they don't feel like they got any benefit from 5 milligrams a day and then the 10 milligram a day dose, I'll probably switch antidepressants. If they felt like, oh, you know, I feel a little bit better, but just not quite back to where I want to be, then sometimes I'll augment with another agent. So that's kind of how I do that. Or if I could push the dose a little bit higher, let's say I started them on sertraline and I got to 100 and they're like, I feel pretty good, but don't feel quite where I want to be, then I might push the dose on that one just a little bit higher. And then obviously the next approach would be consider geriatric psychiatrist. There's not a lot of geriatric psychiatrists out there. And so just talking to your general psychiatrist may be also something to be done as well. Often I think having that conversation with the general psychiatrist is helpful. And so these are not patients typically, especially if I'm worried about them or if they've been depressed and I've tried something else and they just didn't respond to my treatment. Often I will call the psychiatrist and say, hey, this is what I'm looking at. This is what I've tried. This is what I've done. This is what we've seen. Where do you think I need to go next? Or I'd like you to see them and I'd like you to provide some recommendations. And I found them to be very helpful. Thankfully, we now have a geriatric psychiatrist in Sioux Falls that I have a pretty good relationship with. And so sometimes I'll just touch base with them. We have one that's at the VA as well that does pretty good. And so sometimes I'll touch base with that one if it's a VA patient. And so trying to find, and sometimes trying to find maybe a psychiatrist in your area who you've worked with in the past on geriatric patients and has done fairly well is also not a bad thing to think about. Kind of just like you did with cognitive behavioral therapy, trying to find somebody that kind of is a little bit more closely aligned to your philosophy and treatment as opposed to something different that is very helpful. And so trying to find those individuals in your community is always very good because then they can become a resource and become very helpful to you. I've found that sometimes when I refer to the psychiatrist, not the geriatric psychiatrist, that sometimes they're like, well, you didn't try this. And I was like, oh, that's so simple. I should have tried, you know, I tried them on started them on an SNRI because they had some pain and I didn't switch them to an SSRI. I don't know why I didn't switch them to an SSRI. I just wasn't thinking, and they switched them to an SSRI and did just perfect. And so that's the other thing that you want to think about from a non-responder. Next. Back to our case study, we did increase the escitalopram from 5 milligrams up to 10 milligrams in between visits. So I think after about a week. So when I first started in medical school and residency, it seemed like they always said, oh, it takes so long for these things to start. You put them on a dose, 5 milligrams, you see them in 4 weeks or 6 weeks, and then you up to a dose. But most of the evidence here has said, you know, after 7 days, just increase the dose to the therapeutic range. You start them on lower than therapeutic, you do that for 7 days, you increase them to therapeutic range, you can do that for, you know, 3 weeks, and then you can kind of reassess and see if they had any benefit. If they didn't have any benefit, as we talked about, maybe you'll switch. But he was increased from 5 milligrams after about a week to 10 milligrams. He was doing very well at the next visit. He has been participating more in activities. He's been sleeping less. He was going out of his room a little bit more and just seemed to be a little bit more involved in the community. And so the 10 milligrams of escitalopram did very well for him and seemed to help his symptoms. Next. Now we're going to switch gears completely. So we talked not too much about suicidal ideation, but I think that's the next piece of depression that we need to focus a little bit on. And so this patient that we were talking about did present with some suicidal ideation. So I kind of left out a little bit of that in the previous discussion just because of the fact that we wanted to talk about it here. So he, in talking to him in his first visit, he said, "I no good anymore, no sense for me to be around." So again, he had some of that kind of, I'm worthless, I'm helpless, there's no reason for me to be around. My kids don't visit me. I'm alone. There's nothing for me in this world that makes me feel good. And so those things were the things that he was saying, and he was talking about potentially suicidal thoughts. One of the things that when you ask about suicidal ideation, I think one of the key things is it doesn't plant the idea into their head. These depressed patients that are suicidal have been thinking about suicide already. So asking about it is not going to plant that into their head. And then the goal when you're thinking about suicidal ideation is to stretch out the time frame. So obviously there isn't any magic medicine that I can give you to make you not suicidal. The goal is to try to help, just like with depression, stretch out that time frame, get the treatments time to work, allow some of that suicidal ideation to kind of dissipate and kind of settle down. And as you stretch that out more and more, you do a little bit better. Of course, just as we've seen with COVID, as we turn the peak down off to the side, there is still cases going on now. And that's partly because we turn the peak over to the side. So as we stretch out suicidal ideation, that may make the suicidal ideation last a little bit longer, but hopefully it's not as intense. And hopefully we can manage that with some of the non-pharmacologic treatments and to give our pharmacologic treatments time to work. There is a hierarchy of that ideation. When you think about suicidal ideation versus intent versus means, there's kind of a stepwise that they go through. So ideation is kind of the first thing. It's troublesome. No need to jump to conclusions. It's not, if they're just thinking about suicide, that's not as severe as if they have, intent. So they actually have, a plan that they created, or maybe they've thought about it a bunch and are really thinking that's the best option for them. That becomes more problematic. You need to start with a treatment. If they've just thought about, I've thought about suicide once before, that's an ideation as opposed to intent, where they've been thinking about it more and thinking about that being their best option for treatment or for what they feel is going to be best for them. And so that intent is more problematic, more concerning. And then definitely if they have thought about plans or means to carry that out, that's where that's the highest risk. And so those are the people that you really want to focus on the most. Those are the people you want to really stretch that time frame out for. Next. Risk factors are very similar to the risk factors for depression, though you do see that we added in a few things. White men are a little bit higher risk for suicidal success than other populations. Somebody that's single or somebody that is widowed is added in. Military service gets added into this, and so those things are kind of big risk factors and things. If they're talking about this, like this gentleman was a 77-year-old white gentleman who was widowed, and so all of those things make you think a little bit higher risk, and so that's something that you pay a little bit of attention to. If they had adolescent suicidal risk factors, or if they had a previous suicide attempt or a family history of suicide attempt, those also get added into this difficulty. Access to lethal means, that might be something you pay attention to. Do they talk about having guns in the home? Do they talk about having pills at the home that they think they can overdose on and cause them to die? That would be another thing that you want to pay attention to, especially if they mention that to you in the encounter. I've had a few patients mention that to me in my practice, and I get a hold of the psychiatrist right away and talk about what the next steps are. Personality disorders can cause some difficulty with that. Again, unable to communicate also is a problem. Homosexuality, especially if they're experiencing harassment, is an increased risk factor. And so all of those things kind of are the things that you think about: anorexia nervosa, and then social isolation. So fortunately, if you have somebody that's at a nursing home like this gentleman was, maybe that risk factor is a little bit lower just because of the fact that he is not socially isolated, though there again, you still worry. Next. So assessing for suicidal ideation, use the geriatric depression scale, or the geriatric depression scale actually has some key questions that may make you think a little bit that they are suicidal. Obviously, the PHQ-9, the last question, is kind of the suicidal question in that one. But the geriatric depression scale, do you feel happy most of the time? That might be something that clues you in, just as this patient, right? He said he didn't feel happy very often. He didn't feel like he felt like his life was empty. And so those two things can clue you in that maybe suicidal ideation, and maybe you should ask that question directly. Do you think it is wonderful to be alive? Another good question. Do you feel that your situation is hopeless? And do you feel pretty worthless the way you are now? So those 5 questions really kind of maybe clue you in that suicidal ideation should be something you ask about, or suicidal thoughts are something that they've had in the past. And so that might be a good question to add in if you are doing the geriatric depression scale and they answer yes to 1 or 2 or 3 of these. Next. Beware of passive suicidal ideation as well as active. We're running out of time, so I'm going to kind of go through this fairly quickly. Active, more aggressive forms of suicide, they're going to use weapon, poisoning, hanging, tend to be seen in the younger patients. Passive is more, I'm not going to eat, I'm not going to drink. I've definitely, if you practice in geriatrics long enough, they say, I'm done eating, I'm done drinking. Those are more of the passive. They have a tendency to be seen in the older population. And so you need to assess our older population more for some of those passive things. And I've definitely had patients tell me that I'm not going to be eating anymore. And then we have that conversation about suicidal ideation. We talk about stretching that out, not often with the patient, but sometimes with the staff at the facility. And so those are active versus passive suicidal ideation, important to distinguish. Next. Suicide prevention is a collaborative approach, just like all geriatrics. You need to have as many people that you can get involved in that team as possible. Primary healthcare provider, nurses, social workers, psychiatrists, therapists. Education about treatment options. So you want to educate that patient about what options there are. Brief psychotherapy is also very helpful. And then close follow-up. So that's why we had close follow-up in this individual that had depression, is because we were worried about some of his suicidal ideation. And so we had close follow-up to make sure we were getting better. Next. All right, that's it. I didn't leave you too much time, sorry.
All right, does anybody have any questions? Go ahead and feel free to unmute yourself and ask, or throw them in the chat box and I will be sure to read them.
So very well done, Joe. Thank you. Don Jervich here. I was wondering, how often do you see older adults on 2 SSRIs? Trazodone plus citalopram.
I see that more than we should be seeing that, I think. So I think that's something to key in on. I had a patient, I just took over a bunch of patients at a nursing home. Several doctors here in Sioux Falls have retired. And so they were all looking for patient or provider, and so they chose me, and I have been going through trying to clean up some of that. I'm like, why are you on escitalopram and sertraline? Wait a second, we need to get rid of one of these. Or you'll find them on escitalopram and an SNRI, and often I will get rid of the SNRI or the SSRI depending upon if they were using one for pain or something like that. So I do see that more often than, and that's something that you should pay attention to. You need to watch for having 2 SSRIs on board and weaning off one or the other. Thank you for that question.
Does anybody else have anything they'd like to ask or any comments? Okay, we do have a question in the chat box actually. Nancy Joyner would like to ask, what about medications to avoid?
Are you meaning antidepressants to avoid, or are you meaning just oral medications that you should avoid? That would be helpful to know.
The interactive ones, the ones that you want to be careful with, interacting, especially if they're on the SSRIs, etc.
I watch out a lot for tramadol. That's one that I pay a little bit of attention to, and sometimes the antibiotics. Linezolide is kind of a concern, and so you have to watch out for that. Any of the serotonergic type medications, especially if they're on an SSRI, you want to watch for, and so pay a little bit of attention to that. Tramadol, the linezolide is one that I pay attention to quite often. I think Reglan might have a little bit of that interaction, so you have to watch for that in somebody with an SSRI, because that can cause a little bit of that problem with serotonin type syndrome. And so those are the things you want to watch, is serotonergic type medications. Those are the main ones that I think of off the top of my head. Unless any